Hello and welcome to WHO in Geneva. I'm welcoming you to today's virtual press conference on global health issues. It is Thursday, 5th March, and we at the headquarters in Geneva. We will specifically talk about global health issues at all, but also including the progress on cervical cancer elimination, and we'll be joined by senior officials from India and South Africa. We'll have updates on the WHO acceleration plan to stop obesity, and of course, we will also tackle the health implications of the Middle East conflict. For the journalists online, please make sure that you identify yourself clearly. We will not be able to take questions if you don't put your name and agency clearly into the system, and please raise your hand with the raise your hand icon once it's time for questions and answers. Now let me go to our panel today. First of all, we have Director General Dr. Tedros Adhanom Ghebreyesus. Then we'll have Dr. Jeremy Farrar, Assistant Director General for Health Promotion and Disease Prevention and Care. We have next to the Director General, Dr. Kate O'Brien, Director for Immunization, Vaccines and Biologicals. We also have Ian Clark, the Incident Manager for WHO's Emergencies Program. To his side is Dr. Teresa Kasayeva, Director, Department for HIV, Tuberculosis, Hepatitis, and Sexually Transmitted Infections. On the far other end, we have Dr. Luz de Regil. She's the Head of Department of Nutrition and Food Safety. Now, we also have three very specific and special guests, and I'm very glad to be able to welcome them. We'll have His Excellency Jagat Prakash Nadda, the Minister of Health and Family Welfare of India. We also have His Excellency Dr. Aaron Motsoaledi, the Minister of Health of South Africa. And we're also very happy to welcome our Regional Director for the WHO Eastern Mediterranean Regional Office, Dr. Hanan Balkri. Welcome to all of you. And now over to the Director General for the opening remarks.
Thank you, Christian. Good morning, good afternoon, and good evening. And a special welcome to our guests today, His Excellency Mr. Nadda, His Excellency Minister Motsoaledi, and our own RD Hanan Balkri. You will be hearing from them in a few moments. Today, WHO is providing an update on 3 diseases where we are supporting countries to use powerful new tools to prevent disease and save lives: obesity, HIV, and cervical cancer. Yesterday marked World Obesity Day. Obesity is one of the greatest health challenges of our time, but it's a challenge that we have more and more tools to address, including GLP-1 therapies. In December last year, WHO issued our first guideline on the use of GLP-1 therapies for treating obesity in adults. Medication alone will not reverse obesity, but it can help as part of a comprehensive approach that includes healthy diets, regular physical activity, and support from health professionals. The guidelines generated significant global attention and interest from countries who want to integrate GLP-1 therapies into obesity care. WHO is supporting them to do that, and yesterday, colleagues from WHO published a paper in The Lancet Global Health on our work to prepare health systems in 12 countries to strengthen obesity services, including GLP-1 therapies. Through the WHO Acceleration Plan to Stop Obesity, we're supporting 34 countries representing 1.3 billion people to reduce obesity prevalence across all age groups by 5% by 2030. Many countries are taking action, from taxing sugary drinks to integrating obesity care into primary healthcare system. WHO calls on countries to scale up the use of all tools to prevent and treat obesity at all ages. One of the other defining public health challenges of the past 50 years is HIV, but it's also one of the defining public health successes. Once a death sentence, HIV can now be controlled with safe and effective medication. As a result, the number of annual AIDS-related deaths has dropped by 70% in the past 20 years. In recent years, the same medicines that are used to treat HIV infection have also been used to prevent it in people at risk. Last year, a new medicine was approved for the prevention of HIV, lenacapavir. That's the most important development in addressing HIV since the first antiretrovirals were approved almost 40 years ago. Lenacapavir is not a vaccine, but it's the next best thing, a long-acting antiretroviral taken once every 6 months by people who are HIV negative but at risk of infection. In trials, it has been shown to prevent almost all cases of HIV in those at risk. In July last year, WHO published guidelines on the use of lenacapavir, and in October, we pre-qualified it. The WHO stamp of approval that gives the green light to the Global Fund to buy the medicine and begin shipping it to countries. It's the first time WHO has developed pre-qualification and guidelines in parallel, not in sequence, to speed up equitable access to innovative new tools. In the past 8 months, WHO has supported 9 countries to roll out lenacapavir to people at risk of HIV, and these countries are Eswatini, Kenya, Lesotho, Mozambique, Nigeria, South Africa, Uganda, Zambia, and Zimbabwe. In October last year, South Africa's national regulator became the first in Africa to approve lenacapavir and only the third globally. In his State of the Nation address last month, President Cyril Ramaphosa said that South Africa is planning a massive rollout of lenacapavir. And just today, South Africa announced that it plans to manufacture lenacapavir locally. One of the challenges we face is that demand is outstripping what countries have ordered from donors who buy lenacapavir from manufacturers. WHO is working with countries, donors, and manufacturers to meet this demand. Another powerful tool that's changing the face of public health is the HPV vaccine, which together with screening and treatment is giving the world hope of eliminating cervical cancer. Yesterday was HPV Awareness Day, drawing attention to a family of viruses that are responsible for several cancers, including cervical cancer. In 2018, I issued a global call for action to eliminate cervical cancer, which was followed in 2020 by a global strategy with the 90-70-90 targets. 90% of girls vaccinated, 70% of women screened, and 90% of women with cervical cancer or precancerous lesions treated, all by 2030. Since then, nearly 60 countries have introduced HPV vaccination, and 162 countries now include the vaccine as part of their national immunization schedules. Today, we're proud to celebrate 2 countries that are making major progress toward cervical cancer elimination: India and South Africa. Last week, India announced the largest free HPV vaccination campaign in history, targeting almost 12 million girls aged 14 every year. More than 127,000 women in India are diagnosed with cervical cancer annually, and about 80,000 women die from the disease. I commend Prime Minister Modi and the government of India for their leadership on this critical issue. To say more, I'm delighted to welcome India's Union Minister of Health and Family Welfare, Minister J.P. Nadda. Minister, congratulations and thank you for making the time to join us today. And you have the floor. Namaste.
Excellency, Dr. Aaron, my esteemed colleague, Director General of World Health Organization, my esteemed colleague, Dr. Tedros, colleagues, friends from media, good evening and namaskar. It is my pleasure to address the press conference on an important theme of elimination of cervical cancer, along with other pressing global health issues. I represent a nation where health and dignity of every woman is not just a policy aspiration, but a solemn national commitment. Today, I would like to share with you the landmark measures India has taken in its relentless fight against the devastating yet preventable cancer, cervical cancer. Cervical cancer remains a formidable public health challenge, both globally and in India also. Recognizing the gravity of this issue, India has committed itself to a comprehensive strategy aimed at reducing the burden of cervical cancer. These strategies include: first, screening for the cervical cancer is now available at 181,000 Ayushman Arogya Mandirs, which we also call as health and wellness centers, across the country as a part of population-based screening for early detection and treatment. Over 86 million women have been screened under this initiative. Besides, state-of-the-art hospitals in the country, establishment of daycare centers has taken cancer near to home for citizens. This platform provides me an opportunity to share with you a milestone that marks the chapter of India's first against cervical cancer. And that is on 28th February 2026, Honorable Prime Minister Shri Narendra Modi ji launched the nationwide HPV vaccination campaign, targeting 12 million eligible girls aged 14 years. India has joined the community of 160 countries in global fight against the cervical cancer. This vaccination campaign is being carried out over 90 days and follows a single dose schedule as recommended by World Health Organization and the National Technical Advisory Group of Immunization. The vaccine is provided free of charge at designated government health facilities, Ayushman Arogya Mandirs, community health centers, sub-district hospitals, district hospitals, and government medical colleges and hospitals, in the presence of a dedicated medical officer for management of adverse events following immunization, if any. After the campaign, HPV vaccine will be fully integrated into India's universal immunization program and continued at the government health facilities during routine immunization days. Leveraging digital technology, Government of India has developed a digital UWIN platform which captures end-to-end records of all vaccinations under Universal Immunization Program, which provides for administration of 11 vaccines for 12 vaccine-preventable diseases to all eligible children and women in the country. HPV vaccinations will be recorded on UWIN platform, and vaccine stocks and logistics will be managed and monitored through eWIN system. The HPV vaccination is entirely voluntary, and parental consent is a must to align with the community value systems. Transparency and countering misinformation and overcoming hesitancy by underscoring the long-term benefits of the youth of the country is another key component of this campaign. However, we need to remember that vaccination alone will not suffice to eliminate cervical cancer. Screening and awareness must continue. So a comprehensive strategy integrating vaccination, screening, and timely treatment offers the most efficacious path forward. By aligning our national efforts with global cervical cancer elimination goals, we are not just providing medical intervention, we are securing the core resilience of our society. Together, let us protect our future generations, uphold the dignity of our women, and succeed in our fight against cervical cancer. Thank you very much for giving me a patient hearing. Thank you.
Thank you, Minister Nada, and once again for your leadership and time. And WHO looks forward to supporting you on this journey. Now to South Africa. I referred earlier to President Ramaphosa's State of the Nation address last month, in which he announced plans for a massive rollout of lenacapavir. In the same speech, he also committed to ensuring every girl between 9 and 14 receives an HPV vaccine. WHO is supporting South Africa to develop a comprehensive national strategy for cervical cancer elimination. To say more, I'm delighted to welcome South Africa's Minister of Health, Minister Aaron Motsoaledi. Dr. Motsoaledi, thank you for making time to join us today, and you have the floor.
Yes, good day, Excellency, the Director General of the World Health Organization, Dr. Tedros Ghebreyesus, my colleague, the Minister of Health from India, Excellencies, ladies and gentlemen, thank you very much for this opportunity. Cervical cancer is preventable through the vaccination of girls between the ages of 9 and 15 years, preferably prior to sexual debut. It is also curable if detected early, yet it remains the leading cause of cancer death among South African women, with over 11,000 cases and nearly 6,000 deaths annually. Given such a high rate of mortality and morbidity, South Africa will strengthen and accelerate the implementation of the strategy for the elimination of cervical cancer for South Africa. As the Director General has already said, the President of the Republic of South Africa, His Excellency Mr. Cyril Ramaphosa, has elevated this program as highlighted in the State of the Nation address when he stated South Africa will achieve this noble objective of eliminating cervical cancer. In the next few weeks to come, we will officially launch a campaign for elimination of cervical cancer using the global strategy adopted by the World Health Organization with the targets of 90-70-90. In South Africa, I used to mention that we are already very lucky. Noting the severity of this disease, we started as far back as 2014 to vaccinate young girls for HPV between the ages of 9 and 15 at schools throughout the Republic of South Africa. We have up to so far reached 6 million school girls. We are very grateful for the report or the conclusion of the WHO that one dose is enough, because we're giving 2 doses every year since 2014, one in September, one in February, and the second one in October every year. We are very grateful to start the 1 dose vaccination campaign because of shortage of money. We were only targeting public schools in the Republic. We have taken a decision that now will go to even private schools and independent schools to reach more girls because now we have got more doses. So we have already started in our TV adverts around the country to announce our decision for the campaign to eliminate cervical cancer. Now, when we launch this program, we are going to put emphasis on the middle 70 and the last 90, which we know are very difficult. That's why we are going to put a lot of focus on the first 90 to make sure that we reach as many young girls as possible. We are so serious about this program that we've decided that the launch must be headed by the president himself. In other words, it's no longer the Minister of Health who is going to launch this campaign to end cervical cancer. It will be the president himself. So we are just waiting for a suitable date from the president. That's why I'm saying in the next few coming weeks, we'll be launching the campaign. We'll very much appreciate the help and support of WHO. Thank you very much.
Thank you, Minister Motsoaledi.
And unfortunately, DG, unfortunately, my apologies. I am today chairing a very important meeting of all the 9 health MECs or provincial ministers of health in our province, together with South African Local Government Association and South African Military Health Services. It is a statutory meeting for the country, and so I'll be asking to be released because I have just asked to be excused for a short time to come and attend this press conference. If you agree, DG, may I be released now, or if there are any questions which we need to answer, we'll answer them. But I will leave my advisor, Dr. Nonosi Milela, looking in to answer any questions, DG, if you agree.
Thank you. I know your busy schedule. We're actually very grateful that you joined us despite your busy schedule. So thank you so much. And I think Dr. Nono can address the questions if there are questions to ask. But we're very grateful, and congratulations for your progress on cervical cancer. And we are here to support you, and you have our full support. And the same also to Minister Nada to India. Congratulations, like South Africa, for your progress. And we assure you that you have our full support. But we're very happy that progress is happening in the elimination of cervical cancer, which is a very important initiative that we started together, as you remember, some years ago. So thank you so much again. So I appreciate your leadership again, Your Excellencies. Thank you so much for joining us, to both Minister Nada and Minister Motsoaledi. Finally, WHO is deeply concerned about the conflict in the Islamic Republic of Iran and the Middle East, with 16 countries affected. So far, almost 1,000 deaths have been reported in Iran, 50 in Lebanon, 13 in Israel, and 11 in other Gulf countries. In addition, WHO has verified 13 attacks on healthcare in Iran and 1 in Lebanon. Under international humanitarian law, healthcare must be protected and not attacked. The conflict is also causing significant displacement. So far, an estimated 100,000 people have left Iran, and in Lebanon, more than 60,000 people have been displaced, and at least 1 million people may be on the move following evacuation orders in the south. The threat of nuclear facilities being impacted is also concerning. Any compromise to nuclear safety could have serious public health consequences. WHO is working closely with our offices in the affected countries to monitor the impact on the delivery of health services and provide support when needed and requested. But the impact goes beyond the immediately affected countries. Operations at WHO's logistics hub for global health emergencies in Dubai are currently on hold due to insecurity. To say more, I'm pleased to welcome WHO's Regional Director for the Eastern Mediterranean, Dr. Hanan Belkhi. Dr. Belkhi, thank you for joining us at this difficult time for the region, and you have the floor.
Thank you very much. Can you hear me? Dear Director General, dear Excellencies, Ministers of Health, and dear colleagues, the situation across the Eastern Mediterranean is indeed escalating rapidly, with serious consequences for civilians and health systems. Across the region, more than 1,000 people have reportedly been killed and 7,000 injured. One of our most serious concerns is attacks on healthcare. In the past week, WHO has verified 13 attacks on healthcare in the Islamic Republic of Iran and one in Lebanon. In Lebanon, evacuation orders have forced the closure of 43 primary healthcare centers and 2 hospitals. Violence has also affected the first responders, with paramedics killed and injured. At all times and in all places, health workers, patients, and health facilities must be protected, even in war. Last year, WHO's Global Health Emergencies Logistic Hub in Dubai fulfilled more than 500 emergency orders for 75 countries across all 6 WHO regions. However, humanitarian health supply chains are now being jeopardized. The hub's operations are temporarily on hold due to insecurity, airspace closures, and restrictions affecting access through the Strait of Hormuz. This disruption is preventing access to $18 million in humanitarian health supplies, while another $8 million in shipments cannot reach the hub. More than 50 emergency supply requests from 25 countries are currently affected, and $6 million in medicines for Gaza and $1.6 million in polio laboratory supplies are also held up. Half of global humanitarian needs are concentrated in the Eastern Mediterranean region. We are coordinating the health response across affected countries, supporting ministries of health and partners to sustain essential services, as well as strengthening disease surveillance and preparing for potential mass casualties and displacement. WHO is also pre-positioning trauma supplies and essential medicines, supporting countries to maintain critical public health functions, as well as scaling readiness for chemical, biological, radiological, and nuclear risks. Yet our emergency operations across the region currently face a 70% funding gap. Without urgent financial support, essential services will cease and preventable suffering will deepen. However, WHO remains committed to doing all we can for the people of this region and all regions of the WHO. Thank you very much, and back over to you, Dr. Tedros.
Thank you, Dr. Belghi, and thank you for your leadership at this critical time. As always, the best medicine is peace. And Christian, back to you.
Thank you very much, Dr. Tedros, and honorable ministers, as well as our regional director. I think you understood that Minister Motsoaledi and also Minister Nada will both not be available for question and answers, and we thank them for their contribution. Now, we're ready for your questions, and I understand the first question is from Associated Press, Jamie Keaton. Jamie, please go ahead and unmute.
Thank you, Christian, and nice to see you all again. My question is for Dr. Balkhi. Thank you so much for coming to see us. It's so good to see you again. You mentioned the 13 attacks on healthcare in Iran and one in Lebanon. I was wondering if you could give us a little bit more detail as to what those involved, and what you did also mention the disruption in preventing access. What particular concerns do you have about the provision of healthcare in Iran specifically right now because of the violence that's happening there? Thank you.
Yeah, thank you very much, Jamie. Let me look at our regional director, Dr. Balkhi, or the regional emergency director. Let me see.
Yes, thank you very much. I'm happy to take this question. Of course, the attacks on the healthcare in Iran since 28th of February, and according to the head of National Emergency Management Organization, there's 4 healthcare workers that have been killed, 25 health workers have been injured, and 4 ambulances have also been damaged. 11 hospitals and 6 pre-hospital emergency posts were affected in the past 5 days. So most of the health facilities is due to their proximity to these target sites. No structural damage has been reported, only minor damages. When we talk about the healthcare system provision and the support that we provide to our member states in such a situation, we are there. We have an office, a country office present in Iran with staffing at the moment. And I think that we have not received formal requests for any specific supplies as their system is withholding and withstanding the current situation. However, we remain in close communication and contact with the healthcare authorities in Iran and in all of the affected member states within this region to provide the support that is needed.
Thank you very much, Dr. Balki. Next question goes to Emma Farge from Reuters. Emma, please go ahead and unmute.
Yes, good afternoon. I was wondering if you could say more about the disruptions to supply chains. You mentioned your Dubai humanitarian hub. Can you say who those supplies were destined for, in what places of the world, and what needs are they catering for, which diseases or which injuries? Thank you.
Thank you very much, Emma. Dr. Balki, you want to go ahead?
So many of the, I'll give this to Dr. Annette in a minute, but many of the supply chains that goes through the Dubai hub are emergency kits and non-communicable disease kits, but also many other consumables for the healthcare systems within the region and also within other regions of the WHO. The emergency kits that usually are exported out of the Dubai hub are pre-placed in many of the countries facing emergencies and conflict. They are supplies that can last for 3 months to support 10,000 individuals, and they include the necessities of any healthcare system that are needed in a case of conflict. Some of the commodities also are important to go to countries that are in need of the polio diagnostics and kits and so on. And those are because also our region is still including 2 member states that have endemic polio or wild polio in Afghanistan and Pakistan. And the delays in the delivery of these kind of necessities to our member states will definitely have an impact on our ability to respond and address the issue of poliomyelitis, but also not only in the 2 endemic countries, but also in other countries in this situation. Some of the kits that also flow into the Dubai hub and out into the member states are non-communicable diseases kits that support the healthcare systems in addressing and managing the commodities that are necessary for managing diseases such as hypertension, diabetes, and chronic diseases. I don't know if Annette would like to add anything to that or no. Thank you very much.
Thank you very much to the regional director. Next question goes to Stéphane Bussard from Le Temps. Stéphane, please unmute.
Yes, hello. Thank you for this briefing. I have 2 questions. The first is, after the reforms and the austerity measures that WHO has taken, what signals, Dr. Tedros, do you have from member states as far as WHO? Is it still perceived as a key multilateral organization? That's my first question. And the second is, we have in Geneva a global health ecosystem with Gavi, Global Fund, and WHO. And how important is, even though it has been weakened, how important is this ecosystem for WHO? Thank you.
Thank you very much. Are you referring, Stefan, to the Middle East conflict now, or in the more global context, just to get
More
that
global
straight?
context, yeah. Thank you.
So I'm not sure we have anyone today who wants to jump in on this, or do you have Dr. Jeremy Farrar? Okay, Dr. Jeremy Farrar, Assistant Director General for Health Promotion, Disease and Prevention and Care. Thank you.
Yeah, thanks, Stefan. I think we spoke recently on a similar issue, Stefan, and actually I just have come from a member state consultation around global health ecosystems. And I have to say, the enthusiasm that was there and the commitment to continuing to work together in multilateralism was palpable and very strong. And we had also at that member state consultation some really constructive interventions from the organizations you name, Gavi, Global Fund, UNICEF, and many others, for which we're incredibly grateful. Everyone knows there's a lot of discussions going on at the moment about the ecosystem. WHO has a mandate from our member states to host inclusive and diverse consultation on this over the course of the next 8 weeks leading up to WHA. And have to say, I'm very enthused by the consultation we just had.
Thank you very much for this. We move on to Elaine Fletcher from Health Policy Watch. Elaine, please go ahead.
Hi, thanks for taking my question. You mentioned the attacks on healthcare in the region since the 28th of February. I'm just wondering, has the WHO done any tracking of the alleged attacks on health workers during the mass Iranian protests in late December and January, when, according to many reports, regime forces were entering hospitals, attacking and even arresting and killing both doctors and patients? And secondly, can you hear me? Is it okay? And secondly, just during the current war, there's also reports that the regime has stationed itself in some hospitals and schools. Have you got any information on that or any comment? Thank you.
Thank you, Elaine. And I guess we'll look at maybe at the Regional Emergencies Director, Dr. Annette Heinzelmann or Dr. Balkhi.
But can she repeat the second question, because we didn't hear her second question, please?
If I understood well, it's whether any forces have established themselves inside hospitals, whether there's anything on abuse of medical facilities for military purposes.
I've seen.
Yes, you can.
Yeah, over to you if you can.
Yeah, thank you very much for the question. So during the events you are alluding to, we were able, so the situation was quite difficult. However, we were able to verify some of the incidents, and they are the information is available on the dashboards on attacks on healthcare. With regards to the second question on this, we do not have information, and we cannot confirm these events. So, thank you.
Thank you very much. Next question goes to Richard Horton from The Lancet. Richard, please go ahead and unmute.
Hello there. Thank you very much indeed. A question to Dr. Balkhi, please. You mentioned that you are mobilizing support for the Ministries of Health in the region, disease surveillance, and also preparing for mass casualty events, scaling readiness. Could you just give a little bit more detail about your plans for supporting Ministries of Health, disease surveillance, and scaling readiness for mass casualty events? Thank you.
Thank you, Richard, and great to hear from you. Of course, this work does not start during this current conflict. I think, as I mentioned, the WHO has offices in all of the 21 out of the 22 member states. The only country that has a desk office is the UAE, United Arab Emirates. Otherwise, we have country offices in all of the 21 of the 22 member states of the Eastern Mediterranean region. The work that the emergency program, and Annette can elaborate maybe a little bit after my intervention, is that we work with our member states depending on their healthcare system and their situation on preparedness and response as well. So during the peacetime, prior to all of these conflicts happening or these most recent escalations, there has been already a communication on understanding the healthcare system of the country, making sure that their supply chains are intact. I can give you an example. In Lebanon, we have been in a way lucky because before the current escalations that is even escalating this morning from the previous warnings that we had pre-placed some of these emergency kits in Lebanon, and they are serving us very well at the moment. We do, in preparing the member states for such conflicts and also for natural disasters, which also happen in this region, to pre-place these emergency kits. Number two is that one of the several priority activities that take place in the emergency countries is to establish a surveillance system. If they don't have one, then the emergency teams, and we do have team heads for emergency in each of the countries. So apart from the head of the office, we have an emergency team lead that works very closely with the Ministry of Health. And if they do have a functional public health authority, they would be working with them. If they do not, then specific EWAR systems are established to help detect emerging and re-emerging pathogens. Because the biggest worry is when these conflicts take place, then the healthcare system will be affected. But not only that, the infrastructure of the country will be, or the cities, the communities will be affected. The potential of contamination of water, emergence of communicable diseases can create risks of outbreaks of common diseases and even some of the rare diseases, as we've seen in Gaza when polio re-emerged. So these are some of the basic work that we do, as well as making sure that we are able to verify, and the healthcare system, maybe to verify a little bit of that. We do not verify the casualties ourselves or alone. We do that in support of the national authorities and other humanitarian partners on the ground. And as Annette said, that is published on the website. Now, so a lot of the work is done prior to the conflict. During the conflict, then we have to work with other partners, and again, with what we have existing. There are times, and that's why we're very much hoping for this conflict to stop sooner than later, because we worry that the supply chains will be further strained, and we will be losing the capacity to provide the help that is being provided at the moment. There's another concern that worries us a lot is the displaced populations that are taking place. It's already taking place in Lebanon. And Iran, people are being displaced as well. And that also puts pressure on already, for example, in Lebanon, on already fragile healthcare systems that may not be able to accommodate. So we expect that these conflicts will lead to more hardship and more pressure on the healthcare facilities. I don't know if Annette, you want to add anything? Thank you, and back over to you. If there's further elaboration, I'm happy to do so.
Thank you very much, Dr. Balkhi, and we'll go to Ian Clark, Incident Manager for the emergencies.
Thanks. So maybe just Dr. Balkhi mentioned Lebanon, but maybe just to say, to expand on that. I mean, I was there as the Deputy Incident Manager supporting the country office, and really considerable work was done prior to the incident when the pages all exploded. A lot of work was done around trauma training, as the RD mentioned, around pre-positioning, but then also, specifically for triage at all of the main centers and hospitals. So, this really paid off in terms of the actual impact of the response. We saw, how the Ministry of Health and the hospitals were able to manage those sudden influxes of mass casualties. And of course, that's going to be critical now as we go forward in managing the health situation in Lebanon. But that's not just for Lebanon. That's just a case example of some of the work that was done that the RD had mentioned. Thank you.
And thank you, Ian Clark. Next question goes to Christiane Oelrich from the DPA. Christiane, please go ahead.
Thank you, Christian. My question is also to Dr. Balkhi, and it's on the Dubai hub. I don't know whether you mentioned it when I didn't hear it, or maybe you didn't mention it. How many people are actually impacted because supplies cannot be delivered from the hub? And what is WHO's plan B if this hub is not available for for the near future, because there are no guarantees that Dubai will become functionable again in the next 2 weeks or so. Thank you.
Thank you very much. I think we'll have Annette answer that, and then maybe I can come in, or Ian. Over to you.
Thank you very much. So the impact in terms of population is difficult to estimate right now, because it will depend in the end on the question how quickly the hub is functional again. But however, we have alternative plans. So currently, we are working in close coordination with the authorities in Dubai, also with global and regional partners, and with WFP and UNICEF to look for other solutions. So there are potential solutions to provide supplies through land routes, which we are currently assessing, instead of air transport or shipments. There, we are also assessing the possibility to work through our other WHO other logistic hubs, notably in Nairobi and in Brindisi, which are close to the region, but also we are working together with our logistic hub in Dakar to look into alternative shipment routes. And also there is the potential of local supply sources, which we can then use and have shipments through land routes to the different country. For sure, there are some countries where there are higher administrative and logistic barriers to address than in others. For example, access to, for example, Afghanistan is highly complex. However, we are looking into very viable solutions in the coming days or in the coming week for some affected countries in the region. Thank you.
Thank you very much, Dr. Heinzelmann. And just to clarify, this was Dr. Annette Heinzelmann. She's the Regional Emergencies Director for the Eastern Mediterranean region. Next question goes to, hang on, to SABC. That's Sandile Mjesa from the South African SABC. Sandile, please go ahead and unmute.
Thank you very much. Am I audible?
Very well.
Thank you. My question is with regards to the cervical cancer progress in South Africa. The HPV vaccination program in schools. I'd like to find out what has been the community engagement with parents and community members, particularly around health literacy, around the importance of HPV vaccinations. We've seen in the past there's been vaccine hesitancy, and I'm just trying to get a sense of how informed and what has been the community engagement, parent and guardian, as well as learner engagement around this program that will be launched on cervical cancer and HPV vaccinations in schools. Thank you.
Thank you very much, Sandile. I understand we still have online Dr. Nono Simelela. She's advisor to the Minister of Health in South Africa, as advised before. If you're there, please go ahead.
Thank you. Thank you very much for the question. I want to highlight that the South African HPV vaccination program already started in 2014. So engagement with the communities has been quite intense, especially through the school governing bodies, as well as the parents. It must be noted that parents have to give consent for the vaccination, and school health nurses then administer the vaccine to the learners. The community engagement has also included girls out of school who also have a challenge because most of them do not have parents who can give consent. And some of the nurses have given us feedback that they just join the queue because they don't want to be left behind by their peers. And it's quite difficult to refuse to give such young girls the vaccination. But we are continuing our efforts. We've found that information and engagement is going to be quite challenging in the older population once we start intensive screening and testing. And I say that because of the co-infection between HPV and HIV. And we are already working on communications material as well as planning community engagements targeting the older women because we've done quite well with the younger generation in this regard. Thank you.
Thank you very much, Dr. Nono. And let's see, we go to Dr. Kate O'Brien, Director Immunization, Vaccines and Biologicals, please.
Just wanted to add a couple of comments on the importance that you're now seeing at a country level with respect to the one-dose schedule. This is a schedule, as you know, that HPV vaccine can also be given in a two-dose schedule, and country after country is seeing the benefit of switching to a one-dose schedule. It makes the way of administering a vaccine so much easier that it's one time and there's protection for those who are receiving the vaccine. So in South Africa and in India, the really clear examples that you've just seen today, powerful stories from both ministers around just the ability to roll out this program, protect so many more girls. And we have some estimates that as a result of countries switching to the one-dose schedule, something in excess of 30 million additional girls have been able to be vaccinated just because of a switch in schedule. So as countries continue to roll out the vaccine, I think we see more and more that the evidence that has supported the benefit and the equivalence of a one-dose schedule has really driven the impact of the vaccine in protecting so many more young girls as they move into their adult years and protecting them from such a deadly disease. Thanks.
Thank you very much, both. Thank you very much, Kate. The next question goes to Rory O'Neill from Political. Rory, please go ahead.
Thanks very much. Hello, my question is for Dr. Balkhi. Dr. Balkhi, could you please tell us a bit more, if you can, about the humanitarian situation in Gaza and how the regional conflict is impacting on Gaza? Israel is, of course, again closed the Rafah crossing, but it says that decision won't affect the humanitarian situation in Gaza because they say there's already enough supply there. Is that accurate? And how does it compare with WHO's assessment of the supplies there? And yeah, if you could flag to us any other ways in which the conflict could affect the people of Gaza, that would be great. Thank you very much.
Yeah, thank you very much, Rory. And yeah, let's go to Dr. Balkhi.
Thank you very much. I think, of course, the situation in Gaza, and I think our Director General has also spoken about this a lot. The peace process that took place was very fragile, and the amount of humanitarian aid going in was really not and is not enough. There's huge destruction in Gaza that will require a huge lift and a huge amount of supplies that need to go in. At the beginning of this conflict a few days back, the corridors were closed again, and now on the 3rd they have partially opened. So we're still again facing a situation where there is really not enough of humanitarian aid going in, and we still do not have enough of the needed patients to leave Gaza to seek medical care outside. So the situation in Gaza is extremely fragile. We do hope that, again, the situation in the whole region slows down or stops, and we reach a full peace in the region so that we can start rehabilitating all of these communities, cities, people, healthcare workers, healthcare facilities there's a huge lift that needs to take place in Gaza and also in now many of the countries of the Eastern Mediterranean region. So the situation is very fragile. The current situation, and with the Dubai hub being impacted, with the ability of the humanitarian aid to support what is needed in the other countries as well, will take away for sure from the support needed for the people in Gaza. That's something that we also need to pay attention to and keep an eye on. And that's why I emphasized at the end of my statement the need for the humanitarian aid to support the people of this region in a more structured and fashioned way. I think the second, again, can you repeat the second part of the question because I didn't get it?
I must admit I'm also not sure anymore. Rory, in case you need to come in again.
If I didn't ask it, maybe he can ask it again. Apologies.
That's okay. Yeah, the second part of my question was, I think you've already addressed it, to be honest, but it was just whether Israel's statement that there was enough humanitarian aid already in Gaza to see it through a period of restricted supply was accurate. But I think you started to address that already. Thank you.
Thank you.
Right, thank you both. Next question goes to Isabel Sacco from EFE. Isabel, please go ahead. Isabel, sorry. We first have our Director General just add on. Sorry, I missed him, no?
Anyway, thank you.
Yeah, sorry for
No,
confusion.
on the gas, I just would like to add, especially the second question, with some figures. Of course, the ceasefire is welcome, but the improvement since the ceasefire is actually marginal. If I give you some figures, we need 600 trucks to cross into Gaza every single day, but currently it's not more than 100, between 100 and 150. And some of those trucks are actually commercial, and many can't afford, so commercial doesn't really help in humanitarian services. So the progress is marginal. That means since we have identified the situation in Gaza as catastrophic, it's still catastrophic. That's what I would like to underline. And that's actually combined with a collapsed health system. As you know, most of the health facilities are destroyed, and those that are standing only function partially. And then on top of that, as you know, we need to provide medical evacuation to more than 18,000. They're still waiting. There was good progress, but with the recent, as Hanan indicated, with the recent closure of the corridors, that was interrupted, still interrupted, by the way. But even if it's reopened now, there is a discussion that it will be reopened soon. Still, MEDVAC to East Jerusalem and West Bank could help, which is not yet allowed or permission has not been granted. But that would have helped in medical evacuation to nearby facilities in East Jerusalem and West Bank, and like to use this opportunity actually to ask Israel to allow us to take patients to East Jerusalem and West Bank. And then, of course, before the renewed conflict now, Rafah was being used for medical evacuation, but opening all corridors for humanitarian will be very important, because even after the ceasefire, Rafah crossing has not started. The support with humanitarian shipments. So that would increase the number of trucks if permitted. Then, of course, there are added problems, like it's winter now, and we had already documented deaths in kids because of winter, and there are other problems as well that are still affecting the population. With that, Christian, back to you.
Thank you very much, Dr. Tedros. Heads up for everybody. We still have about 5 hands up on the list. Let's see to how many we still get. Next one is, as I just mentioned, Isabel Sacco from EFE. Isabel, please go ahead.
Yes, hello, thank you. It's related to the figures that the director for the Middle East had mentioned, but because for me it mismatched she mentioned 13 attacks on healthcare, but 4 health workers dead, killed, 25 injured, 4 ambulances attacked or damaged. So I would like just to know exactly if when she mentioned these healthcare workers injured or killed, or the ambulances, if how many of them were killed while they were working on duty in any medical facility, and how it relates to attacks or damages to hospital or any other medical facility. To be clear, because I suppose some of them were killed while they were at home or in transit on the streets or somewhere else. So I don't know if I explain myself well, but it's just to be clear on the figures. And if she can confirm that all all hospitals and important medical facilities in Iran are still functioning. Thank you.
Isabel, it was a bit broken, but I get that. We need a clarification on what it qualifies as an attack on health. When does a killed health worker be qualified as killed in the situation or as a private individual? Let me first look at Annette Heinzelmann, maybe Regional Emergency Director, or then maybe here in the room at Ian Clark, exactly. Annette, anything to add from your end?
Yeah, let me take that first shot at it, and then maybe Ian can describe the process. I think what we actually have, what I reported, and I understand where the confusion could happen. So we have, there's lots of inputs in such conflicts. So the countries can report, media can report, but what I had reported on when I said from 28th of February, that was reports by the national authorities. Then the WHO, depending on the current capacity, depending on the severity of the conflict, is capable at certain times of any conflict, and that's what happened here, can verify none of them, some of them, or all of them. So the first part of the numbers is what the Ministry of Health or the authorities had reported. And then when I say WHO has verified the 13 attacks on the healthcare, that is what we in Iran, and then 1 in Lebanon. I think the situation is currently continuous and escalating, and these numbers will continue to vary from day to day based on the capacity and based on the information that comes from the national health authorities, but also from the capacity and the ability for the WHO to verify some of these traumas and injuries. So on your second part of the question is, do the healthcare facilities still stand functional in Iran? And as I had mentioned earlier, the WHO has an office and several sub-offices in Iran, and we are always providing support in the areas that we have mentioned. But right now, it seems that Iran has a strong and robust primary healthcare system, and there doesn't seem to be significant or anything that I'm aware of, and maybe Annette would want to add, on any significant damage or infrastructure collapse similar to what we're seeing, for example, in Gaza. So they have not reached any point which is good for the ability to respond to this current conflict. So I hope this addresses your query, and I don't know if Annette or in Geneva, Ian wants to add anything.
I don't know. Ian maybe wants to. Ian, would you like to answer on the system of attacks on healthcare?
Yeah, thank you very much, Cairo. We'll have Ian Clark answer this one. Yeah, thank you.
Thanks. So maybe just to follow up from what the RD was saying. So in the case of Iran, there are 13 verified attacks. She mentioned also we've had reports of four deaths and 25 casualties. So those are still in process of being verified, and if they are verified, they will be added to the system. In Lebanon, there is one attack. And that has been verified, and that attack resulted in the death of 3 paramedics, and 6 additional paramedics were injured whilst they were evacuating an injured person, so very much on duty. Now, I think the definition of what counts as an attack, if a paramedic or a doctor is at home in their apartment and their apartment gets hit and that person is killed, whilst they weren't on duty, it has removed somebody from the health system. So it will have an impact on the health system. However, in terms of the SSA guidance, that the WHO uses for verifying, we use the process of staff who are on duty. But I think it's important to note that any attack on healthcare, regardless of whether an individual was working or not, it will have an impact on the ability to provide health care to the population. Thank you.
Thank you much, Ian, and thanks both of you. Next question goes to Nina Larson from AFP. Nina, please go ahead.
Yes, hi. Thank you very much for the briefing and for taking my question. So I had just a couple, I needed to clarify on the issue of the logistics hub in Dubai. I couldn't quite tell if you were saying that the value of the humanitarian health supplies that you currently can access was 80 or 18, so 80 or 18 million. That would be good if you could clarify that. And then I was wondering if efforts are underway to switch to overland routes, or if you're trying to negotiate corridors in connection with this to try to get the aid out. And finally, just I was wondering if you could say a little bit more about the concerns around the threats of attacks on nuclear facilities or the healthcare risks connected with that. Thank you.
Thank you very much, Nina, for the first 2 questions, or maybe for all 3. Let's first again start with Cairo.
Thank you so much. I think, yes, the disruption the disruption is preventing the access to 18 million in humanitarian health supplies and $8 million in shipments that cannot reach the hub. So I hope that is clear. On the corridors, as we had said, and as Annette said, of course, we have immediately, and with our colleagues in HQ, this is definitely a 3-level, what we call the 3-level response. And immediately alternatives, first of all, negotiations and discussions with the authorities in the UAE on how to continue to use the hub to the best of their ability in allowing us to do so, is those negotiations have been ongoing. Coordinating with the UAE authorities is the first thing, and also global and regional partners, as we have mentioned, with the WFP and UNICEF and other logistics hub, which we have in Nairobi, Dakar, and Brindisi, to establish other routes. Also, there will continue to be, as long as this gets escalated, we need to be even discussing further, which is also ongoing, all types of potential road routes or ground routes, potentially through the Kingdom of Saudi Arabia, either going west or north. But again, we do hope that we won't need to do so. And I think that the Dubai hub is an extremely important lifeline for the humanitarian response. And attacking the airport or the airport of Dubai being affected and the airspace being affected in this conflict will create a huge impact on the humanitarian response.
Yeah, thank you very much, Dr. Balki. I'm just checking if we have our expert for nuclear risk on board. Dr. Janat, anything to add there?
Yes, I'm here, Chris.
Thank you very much. So, anything you could ask on the question of the nuclear risk situation?
Yes, of course. Thank you for the question. It is understandable that there is a concern about the nuclear risks when there is a military conflict in the areas where there are nuclear facilities or nuclear fuel cycle facilities. And in this regard, WHO has been working with our member states' health authorities and helping them in terms of preparedness and capacity building. For many years, WHO has been conducting training and exercises and providing evidence-based guidelines, protocols for public health intervention, for medical countermeasures, for managing mental health impact of nuclear emergencies. So there has been a lot of work done already. As regard with this specific situation, we are in close contact with International Atomic Energy Agency, which has a mandate and expertise for verifying and assessing the level of radiation exposure. In terms of human health risk, we need to have this information about the severity of the event, about the level of radiation. And obviously, since we do not have yet, and hopefully it will remain this way, hasn't been a verified, confirmed nuclear incident so far, so we cannot really speak and speculate about health risks in this case. We are working with our global expert network also for many years. We are engaging with them. We are fully prepared to respond in case it's necessary. Thank you.
Thank you very much. And this was Dr. Janat Kembayeva, scientist here at our Nuclear Health Risk Unit. Thank you. We have time for one more question. That's the last one we will be able to take, and that's John Lambert for NPR. John, please go ahead and unmute.
Hi, thank you for taking my question. I wonder if WHO has any comment on a couple of actions that U.S. health agencies have taken in recent days. The first is the U.S. delaying the PAHO meeting that was set for April to determine the measles elimination status for the U.S. That meeting seems to have been pushed back to November. And then the second is the U.S. issuing a travel advisory for 32 countries because of polio. Thank you.
Thank you very much, John. We maybe go to Dr. Kate O'Brien, please.
Yeah, thanks for the question. Just for those who are not so familiar, every region has a regional verification committee for measles elimination and for assessing rubella elimination. And the Americas region is no different. There is a PAHO regional verification committee. Those verification committees generally meet on a once-a-year basis on a regular schedule. And for some committees, they operate a little bit differently, and they may meet additionally for ad hoc purposes. So the Americas Regional Verification Committee has decided that they will meet through their regular annual meeting to review the status of measles elimination in the Americas region, and that meeting normally takes place in the fourth quarter of the year. So that's when the review of the evidence will take place by that committee to determine, focusing really on countries that have or may have more than 12 months of circulation of measles in the country, to determine whether they retain or don't retain their elimination status. The second reason for not having a meeting earlier in the year is that it's really important that all of the data, all of the evidence, all of the analysis has been done and scrupulously done and adequately done so that the external committee members can have the information that they need in order to make those determinations. So that's the reason we understand why the committee has decided that they'll review these data from 2025 at their annual meeting in the fourth quarter of 2026. The second question was around a travel advisory from the US regarding polio. I'm not familiar with the recent travel advisory, but I would like to say a couple of things about polio because polio, as is well understood, is a disease that the world is trying to eradicate. And that decision by all of the member states to pursue eradication was made in 1988, and enormous success has been made towards that goal with a 99% reduction in paralytic polio cases. But the main point is that we're not there yet, and there remain many cases of polio. In 2025 alone, there were more than 230 paralytic cases of polio in different countries around the world, over 20 countries. And so it means that until we reach eradication, until the world achieves eradication, every country, children in every country remain at risk. And the reason is that polio is a virus that is transmitted from person to person, and it can cause disease in anybody who is not immune to polio. And the way to become immune to polio is through vaccination. And the coverage of vaccination is under threat in too many countries. And so there are gaps in the immunity that people have, and the polio virus does spread in water. It's found in environmental samples, so in water samples that are not clean water, and in sewage samples. And so I think the important point here is that polio is found and can be found anywhere where there is insufficient immunity. You can certainly see on our website the countries that have environmental samples, which means that this virus is somewhere in the community, and it's being picked up in those sewage samples. So can't emphasize enough that this recovery of immunization programs around the world from the setbacks from COVID are still ongoing. And anywhere in any country where there are pockets of under-immunization mean that those children are at risk of paralytic disease should they encounter the polio virus.
Thank you very much, Dr. Kate O'Brien. I think that was the last question we had time for. Let's thank you all very much. We had a very long briefing today, and I thank you all for your patience and your time, and all the experts and ministers who joined us today, and our regional director, Dr. Hanan Balkhi. We'll be sending the files and the transcript from Dr. Tedros' speech soon after the briefing. Anything else, please to media inquiries at wjo.int, and over to Dr. Tedros for the closing remarks.
Thank you to members of the press for joining us today, and see you next time.